This is A Silent War Within, the podcast dedicated to confronting the unseen mental health battles carried by our first responder and healthcare heroes. This show is about real stories, real struggles, and real ways to survive the storm and come out stronger on the other side. For too long, stigma has kept you silent. But this is your space to bravely break that silence, share vital insights, and build a community where your well-being truly comes first, because your service deserves unwavering support.
Welcome, everybody, to A Silent War Within. We are extremely happy to have you here. As always, you can find us on TikTok, Facebook, Instagram. We also have a website, asilentwarwithin.com. You can always reach out to Kim and I at Kim or Kevin, whichever one you want to use, at asilentwarwithin.com. And we're going to get into part two. We're not going to waste any time. We've got MaKayla Davidson here with us that we had in the previous episode. So this is part two of a very long conversation because MaKayla and I like to talk and we have a lot to talk about. So MaKayla, take it away and let's pick up where we left off.
Let's do it. So I really think that Kim would be happy she's missing this episode. She probably wouldn't get a word in between me and you.
You're probably right.
She would be like, what am I even here for at this point?
Yeah.
But we've missed each other too. So this is also like catch up, me and you.
This is a reunion.
Yeah. So when we left off, we talked about some fun things we're going to talk about. So I interviewed all my friends that work in the hospital setting with me, from ICU to ER to maternity nurses to lab technicians to phlebotomists. I've interviewed everyone and I'm a supervisor where I work right now. So at night, I went around and interviewed all my friends, and I've got the lowdown, deep and dirty about what causes burnout, anxiety, depression, PTSD in the hospital inpatient setting, which is different from what a lot of your other people you've interviewed have dealt with.
So where are you going to start? Are you going to start from top of the list down, or we just want to randomly choose one and just do it?
Before we do that, I think there's two things that we really need to talk about.
All right, come on.
One, and don't let me get off track because you know we will. One is self-defense with all patients. And two is a government mandated staffing ratio. Hot button topics.
All right.
Right off the bat.
All right. Let me start with this one.
Okay.
All right. So story time, because all of my lessons come through stories. I was in Greenwood, Mississippi. And to give you the geography of where I was approximately 6 minutes from the Greenwood police station headquarters, right?
And I worked at Greenwood Hospital. That's right.
I was in a little community. I was in a little community called Baptist Town. Now, many of you may recognize that phrase from the story of Robert Johnson. He sold his soul to the devil at the crossroads in Clarksdale, Mississippi, so that he could learn to play the blues. He came back. He was a very successful recording artist for about 2 years and then had an untimely, unfortunate death. Some people say that was because Satan came to claim his due. But that's kind of the geographic and historical layout of where I am. I'm in his place of birth. So Robert Johnson
was a movie coming out about that, actually.
Yeah, I'm pretty excited about that, actually.
Mm-hmm.
So I was in Greenwood, where Robert Johnson was born, in the very same neighborhood, which since he left that neighborhood has become much more plagued with violence and poverty. And he didn't grow up in any rich, lavish lifestyle either, but it has even worsened since that point in time. So I'm there and we get a call, and of course I go and EMS, somebody call 911 kind of deal. And the door opens, and I don't know if you guys see me, but I'm a fairly large individual. Like, I'm not small.
He's a bigger fella.
Yeah. I've never been a small guy. This guy picks me up like this, as if if we're in WWE, and he just throws me in the yard immediately. No words, no anything. And we knew right then that the fight was on. So radio for help as quickly as we can. Thank God we had a paramedic student riding with us that day, because if it had not been for him, I don't know what the outcome to that would have been. But he goes to just whooping on us. I mean, every one of us. We didn't know he was high on PCP. We knew something was awry, but He was high on PCP, and for 10 minutes, he whooped us. Now remember, 6 minutes from the police station. I'm not going to speculate as to why the cops didn't have a faster response to help us, but 10 minutes we were by ourselves. We fought and we fought and we fought, and there was a certain point in that fight that we realized that we were fighting for our lives. We weren't just fighting to get out. We were fighting to survive. And if you've ever been in that mental headspace, it takes your anger and aggression to another level. And because you're fighting for you. And at the end of the day, every first responder will tell you, if it's you or me, I'm going home. And that's kind of the mentality that we took. We wound up having to beat his head in on the front porch steps, for lack of a better way to put that. It was just a very violent fight. So I had an eye socket broken, and my nose was cracked. It wasn't completely like displaced. It was just had an internal fracture. And one of the moral injuries that I suffered from that was my supervisor came and said, we don't file charges on patients. And my response was, he stopped being a patient the minute he laid his hands on me. That gentleman is still in Parchman, Mississippi today for his actions with probably, I didn't follow up on this, but probably some brain injury of some kind. Because, I mean, we wrecked that guy and he wrecked us. I mean, all of us, by the time we got through subduing him, was kind of laid in the yard like we had been through something, because we had. And in that, I incurred that moral injury, but I also realized that there was a big gap in teaching first responders self-defense. Look at the Idaho shooting just a few weeks ago where somebody started a brush fire. Those guys get called to the scene and get sniped off one by one. That was not a situation that they could have used any self-defense in, but we have to realize that the job we do at its core and just out of nature alone is a dangerous job.
It's dangerous.
For first responders, you're walking up to strangers' houses and knocking on their door and not knowing what's behind that door. Police officers, if you ever watch a police officer knock on a door, he never stands directly in front of the door. There's a reason for that, because people can shoot through doors. But one of the gaps that we found in that particular call was that we didn't have any self-defense training. So there is a program that was created some years ago called DT for EMS, and it is non-lethal self-defense tactics that are taught in this class. And I'm not sure it's even still functioning, but that was just the one that I went and took part in. So I would always encourage first responders to have something, whether it's jujitsu, whether it's martial arts, whether it's some kind of self-defense. It is inevitable that you're going to face a situation where you're going to have to know how to defend yourself. You're going to have to know how to do at least some fighting of some kind, whether it's just to subdue or whether it's like me that you have to actually fight for your life. And thankfully I am a big old fella, because that helped me. It helped me gain some control over the situation. But in a hospital setting, just like I said, working at a large metropolitan hospital, there was numerous times where I had to tackle people running naked down the hall or clothed. I mean, that was neither here nor there. That's just a piece of the detail.
Clothed is preferable.
Clothed is preferable. That's just a piece of the story that always makes it a little comical. But really,
why are they always naked? They're always naked.
I don't know why mental health patients and people in crisis feel like getting naked. I only feel like getting naked if I'm extremely too intoxicated, which has only been a few times in my life. And that's just because I'm hot. Not hot like, ooh, you look good, but hot like temperature hot. I'm burning up. Anyway, that's a side note that nobody wanted. But part of what you deal with in the hospital system is kind of the same thing. No, you're not going up and walking on strangers' porches and knocking on the door. But you are walking into a room and you're really at a point of disadvantage, because they can get the jump on you because it's just one person and you're not suspecting in the workplace that you're going to have this physical violence. But across the nation right now, when you look at numbers, and I haven't researched the actual numbers and statistical data here, but you see it on the news all the time that we are getting attacked at work. We are getting assaulted at work. So it's and the way you deal with this is to teach nurses and healthcare providers how to defend themselves in a way that doesn't cause any physical bodily harm to the patient.
Or themselves.
Because Because when you do cause physical bodily harm to a patient, that's when you get into the lawsuit category, and then you're going to lose your license, and you're going to go through this whole thing of you did something wrong when really you were just trying to defend yourself. But if you implement some type of non-lethal training, or even down to the point of non-lethal weapons that a charge nurse has or is readily available, that you can subdue a patient and make them stop what they're doing, stop causing harm to your staff. And I'm not saying that's the answer. That's just one path that you could take. But it is extremely important that healthcare systems start to teach classes like de-escalation tactics, to self-defense, to non-lethal ways to subdue a patient.
Can I pause you right there, Kevin?
Yeah.
Just for 2 seconds.
Yeah.
A lot of people do not realize this. And if you're listening to this and you're not a healthcare provider or work in a hospital or anything like that, in the hospital, security does not have any means to stop a person from attacking anyone. They have their body.
And
they do not carry tasers. They do not carry anything to help us in a situation of severity. They have their body. So if they're coming to help us with a situation, they're putting their own body in harm's way with nothing else. No taser, no nothing.
And usually
people don't know that.
And usually for about $15 an hour on average.
Yeah.
So, I mean, how much help are you going to get from somebody that is making that kind of cash to put their lives at risk? I mean, you start to put that side by side, and people are inevitably and naturally going to go, it ain't worth this.
It's not worth it.
No.
Let them leave, or let them do whatever they want to do. Step away from them is most of the time what they say, you know?
So you have to realize that part of it too. A lot of it does fall on us. And when things do get chaotic, people kind of expect the nurse to deal with it. Yeah. Or the staff to deal with it. Not necessarily just the security guard or whoever's coming. Like that's not,
I've had a lot of male nurses. I've had a lot of male nurses save my butt before in crisis situations, because when you're a nurse and it's just logistics, most nurses are women.
The large majority.
The large majority of nurses are women. And when you have a patient, let's just put a perfect scenario in place because this actually did happen. Psych patients, when they are not medically well, have to go to a hospital to be treated, to be stabilized, to go back to the psych hospital or wherever they were living. So say they ingest a light bulb, which this actually happened. So this is the scenario I'm given without giving too much details. A patient ate a light bulb and had to come to us to get medically cleared from the injuries he, did to himself. And during the middle of this, he's actually being treated for a mental health issue, a serious mental health issue with a tendency of violence at a mental health facility. This dude is 350 pounds and about 6'5", with a tendency for violence, serious violence, on a unit with all female staff. So when he code grays, which in most hospital is like a behavioral code, right?
Yeah.
When we call the code gray, there is a male nurse that came to help us who physically intervened in front of the female nurses. That's a scary situation. When you talk about safety, the resources in every facility that I've personally been in have not been what they should have been, could have been, would have been for nurse staff safety. Only one hospital that I've ever worked at, and I worked at downtown Dallas at a level 1 trauma center. Only one hospital I've ever worked at had a metal detector when you walk in the door. One of my friends right now, she works in PA, and she had a nurse stabbed in the parking garage leaving work. I've never had a security officer stationed in the parking garage. Not even when I worked in the bad parts of Memphis. I mean, they had one stationed right outside the front door, but not like in the parking garage. I mean, that's pretty unsafe just right there.
And even here in Memphis, we've had car break-ins. We've had healthcare providers shot in the parking lot over a carjacking gone wrong. There's been numerous times in Memphis where nurses have faced assault from a with either a deadly weapon or without, that they're just trying to get home. They're just trying to leave their workplace. And I think that one of the things that we have to implement for in-hospital staff is the fact that we have to know how to de-escalate situations, and we have to know how to defend ourselves. So what was your next question that you had that we were not supposed to get off about?
We're not supposed to get off topic. It was government mandated staffing ratios, because right down the road, I'm on New Hampshire seacoast. About 15 minutes away is Massachusetts, and Massachusetts does have a government mandated state nursing ratio. What is your hot button thoughts on staffing ratios?
So if you let the government start getting into too many things, and they already are, this is just an opinion of mine. If you let the government get into too many things in healthcare, they start to gain control. Government control usually does not work well in a situation that's not black or white. Healthcare is very gray. When you have something like finance where you can sit down and you can see numbers, that's a black and white topic. You can see we bring in this much money, we put out this much money. That's black and white. There's not a lot of area for gray when you're talking about mathematics. But when you get into a hospital setting where you are dealing with patients and things are constantly changing, there are very gray areas of what we do. And I think one of the things that you have to take into account is if you do a government mandated, whether it's from local government or whether it's from state government or whether it's even all the way to the federal government level, you have to think we are such a diverse system in healthcare. So you can put out a number that says, oh, the state mandated ratio is 5-1. Well, that doesn't do anything for the ICUs, because the ICUs typically are somewhere 5-1, 4-1, 3-1, depending on what ICU you're in, or sometimes even 2-1. Big specialty hospitals, like, for example, St. Jude, they're at a 2-1 ratio no matter what, because that's what they found to be safe for their type of patients. And they're kind of like Oz. They're kind of like the Emerald City. They're the sought after place to work because of those type of things. And that's why they're sought after, because they pay their nurses a living wage and they have these patient ratios that are really good and decreases burnout from their staff. That's why people go there and stay for years and years and years and retire from St. Jude. One of the things that you have to take into account, though, back to my original point, was that if you do a sweeping, and this is what government does, they love sweeping bills that take care of multiple problems at one time. They're going to put out something that says 5-1 for all hospitals. That may accomplish your goal on med-surg floor or PACU or any of those other places that you have within the hospital, but does it solve the problem in the ICUs? Well, no. So you have to be, if government got involved with that and we had patient ratios that were mandated, one of the things that you have to do is be unit specific. And because we are so many units, it would take a lot of research for even local government to come into their local hospital that maybe they own and run from a governmental standpoint to come in and say, what are your patient ratios now? Like, there's a lot of research and data that has to happen before we can say, yes, we're going to go mandated patient ratios. But I think that hospital systems should adopt policies instead of governmental sweeping legislature or mandates or things like that. I think hospitals should adopt policies that are safe for the provider and for the patients. One of the things that we chronically do, and we talked about this in our call yesterday, was the fact that we have nurses that are not paid a living wage. Is $30 an hour a living wage now?
We talked about this yesterday.
Yeah, LNAs. Or depending on where you're from, patient care assistants. Like, they're making very, very nickels and dimes compared to nurses. They're definitely not getting a living wage. But
they
right
pick up
now,
McDonald's and flip burgers for more than what they make wiping butts.
But right now in 2025, is $30 an hour a living wage? And the answer is no. And the reason the answer is no has a lot to do with hospitals that make us pay for our benefits. It has to do with taxes. It has to do with multiple different things. And we can discuss those, but I think the overreaching thing is when does the hourly rate equal $30 an hour bring home? I think that's the math that we have to start focusing on from a hospital system wide. So if you make policies that pay your nurses well and you make policies that encourage safe patient ratios, then you've got something. The one thing that, like I said, St. Jude attracts people because they have safe patient ratios. They have patient ratios that their providers don't get burned out. They don't get in that spot. They may have mental health struggles of other things that are going on. You're in a hospital where death occurs more often than a normal facility would on a general surgery floor or any of the other med-surg floors. But you see a lot of death at a children's cancer research hospital, obviously naturally. But they have safe patient ratios. They have appropriate living wages, and that attracts talent. So if the nursing industry as a whole is going to grow, we've got to, and this is a whole different topic that I think we talked about yesterday, but if the nursing industry is going to grow, you have to have those safe patient ratios. You have to have a livable wage. And we've got to, the other part of it is we've got to quit being so harsh on our profession. We've got to quit being so harsh on the way that we talk about our profession. Because like we said yesterday, if somebody comes to you and says, MaKayla, I want to be a nurse, our immediate thought is, no, you don't.
What's the first thing we say? I'm sorry for you.
Don't do it. Don't do it. I'm sorry for you. Yeah.
Yeah.
And we have to be mindful of the way that we paint our profession, because even though there are those inherently bad things that we deal with, there are also good things that we deal with as well. And if we start to label some of those things and you put those on a piece of paper side by side, I would almost guarantee that you may find that you have at least just as many good as you do bad. And if we focus more on the good, positivity spreads like wildfire, just like negativity does. So if we start being more positive about what we're doing and the help that we're providing, one of the things that I hate in EMS is the fact that we've painted this hero mentality, and we talked about it on one of the episodes we did, but we've painted this hero mentality, and where that stops is in school when you're first entering the industry and you're looking at it and you think you're going to do this heroic thing every single time you get called, and that's just not the truth. You're going to go pick up Mama that's having problems urinating for the last 3 days, and you're going to take her to the hospital.
And then she's going to fight you the whole way there.
And then she's going to fight you. Like, that's not heroic. That's not what feels heroic. Being on the side of the road, pulling people out of burning cars, that feels heroic.
Right.
And I've done those things too, and those feel great, but that's not an everyday occurrence. So we've got to start training not just our EMTs, our paramedics, and our firefighters and our nurses. Firefighters are the exception to the rule, because when you go to a fire, it does kind of look pretty heroic. I know why firefighters are loved so much. It's a cool job. And I did it for 2 years and didn't really care for it. It wasn't my thing. It wasn't something I was passionate about. I'm fat. It's hot. They don't mix. But one of the things we've got to stop doing is being so harsh on our profession. Look at the good things we do. Stop setting people up for failure when we tell them what your job really is. So I think those are the two biggest things that when you start talking about mandated patient ratios, that you move to a policy kind of avenue versus a mandated. The problem where it would have to be mandated is healthcare systems are not going to do that. The only way to make it that way, because they're going to get the most for the least amount of money. Yeah, it would have to be a law. If you could get facilities to rationalize like this is safe, then you would have movement in that direction. But I don't think across the board you ever get that without there being some form of government that gets involved with it. So I think that it's something that hopefully we will eventually work toward. But I think hospital systems can start to turn the tide now. And once you have those few hospital systems that have that success and can go into legislature and say, look at this, look at what's happened in our facility. Yeah, look at our data. And that's what we were just talking about in a meeting this morning. One of the things that I've kind of unofficially outlawed, my watch, unofficially outlawed is you can't come to me with, I feel, when you're talking about processes and improving things and just the logistics. Like if you come to me and say, I feel like I'm not in a good place, that's different. I'm talking about just logistical change in the side of how we do our job. You can't come to me with, I feel or this is the way we've always done it. I hate those two phrases because feelings don't move the needle when you talk about processes and the way that you do your job. What moves the needle is showing evidence by data, because then you can go to the people higher than me, higher than you, and say, look at the data that I have that shows this is a promising avenue for us to go down. This will cost us money in the beginning usually, but it will make us a ton of money in the back end if we just invest in this set of people, in these patient care reps, and say, these nurses, these RTs, these LMAs, all these things, that's how we get there, is for those few systems to start that program and show the result, because the result is going to be evident.
Let's get down to the real keyword you said there, Kevin.
I saw you make a face.
Let's get to the real tea. I'm all about spilling the tea
Oh, here you go.
What do Southern women love to do? What do Southern women love to do, Kevin? Gossip.
Gossip.
Okay?
Y'all love the gossip.
We love the gossip. This is not gossip. This is real life. This is tea. So
this is facts.
Facts. As much as healthcare systems are this loving, safe, we're helping patients environment, it's a business.
It is.
It's a money-making business. Even nonprofit hospitals have to keep the lights on and pay the bills.
Yep.
Okay.
Yep.
And there's money coming in. I don't know if you know this. Most people don't. If you go to a nonprofit hospital, they're still getting paid.
Oh,
they
absolutely.
Just have to write off so many more things at the end of the year rather than for-profit hospitals. Just so everyone knows that.
Absolutely. You're exactly right.
I think in the next generation, we are going to see a lot of reform simply because there are states in this country that are trying to do it right. And I know I'm from the South. We hate California, but California is on the right track when it comes to healthcare. If you've heard any travel nurse come from California, and I have not worked there, that's just too far.
They all love it. They all love it.
They love it. The staff mandated station, the state mandated staffing ratios. The lunch, I couldn't get my words out. I was so passionate about this. The break nurse. How many times do they scream down our throat about productivity and taking your lunch break? Because it's about money. They don't want to pay you the extra 30 minutes to continue working. They have a nurse that takes your assignment for your entire lunch break and continues the work for you so you can go to break. Am I that boring, Kevin?
No, I just had to yawn. I don't have enough oxygen in my lungs. It's pathophysiology. If they're watching on
Spotify, they're listening on Spotify, they won't see what you did. He just yawned at me, you guys.
I did not yawn at you.
I'm kidding. But for real, California's doing it right. All the nurses there, they love it. And I don't know if y'all know this or not, California's not hurting for money. They're not hurting for money. So I think when this starts to spread and this data starts coming out from California hospitals, it's going to be really truth-telling, because a lot of people don't understand that deaths after a procedure, deaths from sepsis, falls with injury, all of those things that happen in a hospital that make it unsafe to go there, Medicaid and Medicare will not reimburse the hospital for those issues. So if you have a sepsis patient, right, that you haven't provided the correct care for and they pass away, right?
And I think what you'll see a regional shift first, where you see states like Nevada, Utah, all those states that kind of connect, Oregon, all those states that kind of connect to California. You'll see that regional shift first, and then it will start to spread. And it may take 5 or 10 years like everything else does in healthcare. But I think that you're exactly right. I think that California's got it figured out because they have patient ratio mandates, they have higher wages, they have all these things. But if you look at their earnings, they're making more earnings than any hospital systems in the nation on a broad scale. So when you look at that, you say they're doing something right? I mean, I think we'd agree with that. And you see, I think you're going to see that continue to grow and grow and grow over the coming years. To people will start adopting some of those. And I think we've got some really good advocates that are coming from California, but not only there, other places in the United States, like you and I, that are talking about this and going to bring it to the forefront. And all these things you may ask, especially if you're picking up on this show right now, especially like on YouTube or something, you've skipped ahead. You may say, how does this relate to mental health? But these things all relate to mental health. And you pointed out a really good piece of that when you said healthcare is a business. And I used to say that it didn't have any weight behind it, when I said it. Now, from a leadership perspective, I see what that looks like. There is a fine balance that you have to keep from a corporate leadership position to create that revenue, because if the door's closed, you're not going to help anybody. So I think that it's really a fine balance. It is a hot button topic because it is such a fine balance of things that you have to maintain when you're running a health system. And that's very difficult. And I don't feel for those people in those higher corporate positions, because that's got to be a lot of pressure and a lot of stress on them as well. But I would encourage anybody in those positions that maybe listen to this, don't lose sight of why you're doing what you're doing. It's for the patients. And yes, you have to maintain the finances to keep the doors open to help others, but you also have to think about your staff. You also have to think about the patients and what experience they're having. A lot of our reimbursement is based sometimes solely on survey results. Our ratings within the Medicare and Medicaid reimbursement system is based solely on what our ratings are. So sometimes you have to think about patient experience. If you've got an 8-to-1 patient ratio as a nurse, you're not going to be kind to memo number 8 when you go in and change her for the 7th time tonight.
How long did she have to wait after she hit her call light? That's on the questionnaire.
And so those patient ratios do directly affect not only the mental health of the providers, but the mental health of the patients and the overall health of the patients. Like, this is a huge topic that I could probably stay on for much longer than I'm going to stay on it, just for the sake of time, because it is a hot button topic. But I think that there are things that we can start to do and examples that we can start looking at, such as California, to go, this is the way it's supposed to look. So that's my take on it.
When a hospital is losing money, when they don't get reimbursed, I'm not going to name the corporation that I'm with right now, but I will say some things are going to sound very similar to what we're going through right now, where I'm at. When we do not get reimbursed as we thought we were, we're not getting the money in that we anticipated we were. There's budget cuts.
Same thing across the country. That's a everywhere thing.
There's budget cuts. But what we're seeing when we cut those budgets, it directly is a trickle-down effect to who? Who's the last person on the totem pole? The nurses and the LNAs.
Mm-hmm.
You are running tighter. You are taking care of more patients, so they have to pay less people. That's just the nuts and bolts of it.
Exactly.
And that leads to short staffing.
Absolutely.
Then you're going to see, I'm about to start reading my list because we've got to stay on topic or we're going to have another episode.
And why does it lead to short staffing? Because our staff burns out. Now you can go into that's a great segue, MaKayla. You keep doing it.
It's a great segue. We're just great on segues.
You keep doing it.
No one wants to pick up an extra shift as a nurse when you go in and you automatically know you're going to be short staffed.
Well, if you're getting your head kicked in every night, nobody wants to come endure that abuse for 12 hours. Nobody. So go to your list and tell me why somebody. So are you going to pull them out randomly, or are you going to read down the list? How are we going to do this?
I'm going to read down the list of what I've collected kind of just as they came to me.
Okay.
So lab, let's start there. Sometimes at night, and this is other facilities I've worked at too, not just here, there's one phlebotomy tech for the whole hospital. And when their time draws, one. And I'm a nurse. I love sticking people. Anybody that's from my company right now, they know that's true. That's my favorite thing to do is start IVs.
Yeah, me too.
I try to draw my own labs if I can, especially if there's one at night. But when there's one on staff for the entire hospital and nurses are chronically texting them about stuff.
That's too much.
Hey, there was a stat PTT on this patient and you're down in the ER dealing with the trauma. That was one of the things that they said led to burnout in their department. Coworkers' attitude when they're asked to pick up because it's such a small department. When they don't have help, and then you call and say, hey, I need help, and then your coworkers don't want to come to work because now there's only going to be 2 of you.
Yeah.
Still short-staffed,
Short-staffed.
Let's see. X-ray. Let's go to X-ray. Underappreciation from management, or, and added to that was, maybe not even seeing your manager at all if you work night shift. How are you going to feel supported by someone you don't know?
Yep. That's true.
Which I've worked nights before and at other hospitals, and I can tell you that some leadership is better than others, but if you're a manager, you should be seeing your staff at night. They should know who you are.
Absolutely.
All right, maternity. Also under X-ray, this goes back to LNAs as well, but underpayment and low coworker morale.
Mm-hmm.
When everyone you work with is miserable, and it's just I was going to say another word, but a gripe fest all night, all day,
Yeah.
because you're all burnt out. That's the root problem. You're all burnt out. When it's a gripe fest all day and all night, do you really want to come to work another night and hear a gripe fest 100%?
No,
No.
not at all.
And in healthcare, I do feel like that's a double-edged sword, because the squeaky wheel gets the grease. That's just the way it is.
You're right.
And I feel like there's a fine line between sticking up for your department, sticking up for yourself, and just being a Debbie Downer complainer all the time. It is hard to navigate that, because
Sure.
at the end, you don't want to sound like you're just constantly complaining, All right, so let's see. Let's go to maternity, what they said. Short staffing with only specialized nurses. If only a few people that work in the hospital can do your job, when you're short-staffed, you're just short-staffed. There's no float pool person that's coming to help you. I'm sure Shaylee knows exactly about that.
Mm-hmm. Mm-hmm.
If
Yep.
NICU is short-staffed and there's more patients in that
They're
department,
just short-staffed.
They're short-staffed. There's no one
Yep.
coming to help you. There's not these float pool people or anybody that can come to your department to help. If the census is high, you're just short-staffed. Demanding patients, high-risk patients, mandatory overtime. That goes back to short staffing. If you're mandated to come in because they don't have staff that can do their job. No ancillary staff. And provider communication rudeness. The patient demographic is different than 10 years ago. Do you agree?
Somewhat. I'm not going to say I totally agree or disagree. I think it's a lot to do, again, with geographical location. I think that patient demographic changes as you move through different parts of the country, which I'm sure you've seen. Just making a small move from Greenwood, Mississippi to Tate County, Mississippi to South Haven, I've seen different patient demographics in each one of those geographical locations. So,
Entitlement.
That's 100%.
I was trying not to say it.
That's 100% geographical. If you
I
go,
was trying not to say it, but
and I know listeners will likely not recognize the geography of Memphis and where these places are. If you pick up a patient in downtown Memphis, it's a completely different patient than if you pick somebody up in Germantown.
Yes.
And that's because of the entitlement.
Or on the seacoast of New Hampshire.
And the other thing that we've started to see, especially in pediatrics, is the fact that the generation of kids that are currently the young generation, the 10 to 18-year-olds, are extremely entitled that the world owes them something. And that I will admit, that has changed in the last 10 years or so, or even longer. I would even go as far out as 15. The last 15 years, that has totally changed. You can pick up a 16-year-old on a wreck scene 15 years ago, from my point of view, and they're very thankful you came. They're very, all these things. There is a plethora of kids now that when you pick them up on a wreck scene, it's, do you know who I am?
Yes.
Whether that's because of social media, whether that's because of whatever, you have 16-year-olds that are viral on TikTok and they think they're some kind of celebrity. Or you have people who, do you know who my dad is? Do you know who my mom is? And it's not the way it was.
How much money I have. That's a big thing
It's
on
not
the seacoast.
it's not the way it was asked 15 years ago.
Yeah.
So
And
15
plus,
years,
just a thank you to a healthcare provider goes a long way.
long way,
A long way.
for
I
sure.
haven't been
For
told
sure.
thank you in a long time.
Oh,
Like, if
absolutely.
you bring them a water, thank you, yes, but like an actual like thank you for the care you're providing me goes a long way.
Yeah, goes a long way. Continue down your list.
Yes.
So we don't have another episode.
Hopefully we'll be done soon. We've got a lot to talk about. So this comes from a neurofloor, a nurse on a neurofloor. Stress from patient acuity. Patient acuity for neurofloors is high. When you have all of your patients are confused, stroked out, when you're short staffed, you really feel it. When
Yeah.
everyone is, has dysphagia or difficulty swallowing. So they've got a feeding tube. So they're pooping the same stuff that's going in their nose.
Yeah. And I think that that rings true with probably every ICU, if I had to guess, because that's the complaint Shaylee had. Like, patient acuity does lead to increased burnout, especially when you're taking care of 10 ventilated patients, a night.
Yeah. And you're already short staffed on top of the patient acuity that's really high in that department makes it even worse.
Right.
The hospital that I work at now is very good about this. So I will give them props to that. But when you're pulling resources away from the floor, LNAs to be patient sitters. So you're already short LNAs and you're pulling an LNA to go sit when you don't have a department of safety sitters.
Yep.
The hospital that I work at now does a great job of that. They have safety sitters. Not always if they're not staffed, but that's every hospital. That's been since the dawn of time. Productivity. Oh, this is a hot button topic at where I work. Productivity as appointed by the higher ups. When you hear productivity, you think of a nurse being productive, right? Not as a metric for how much money we're going to make. You can only cut so much fat before you hit the meat. And the meat, unfortunately, is patient safety.
Yeah.
That's just the nuts and bolts of it. I'm going to tell it how it is. I've never stopped before. I ain't going to stop today.
No, just the way you put it was very Southern.
What, about the meat? About the meat and the fat?
Yeah.
Yeah, it's true. You can cut and run with as short of staffing as you can to make the most money.
And
right?
eventually it cuts into what it really
cuts into
is
patient
and
safety.
patient safety. Yeah.
That's true.
No, I get what you're saying. I just laughed
Foresight for upper management. Planning, provider. Let's stop just for a minute so I can get on a little hinge here because I'm getting to some points that I'm really, really passionate about. Foresight for staffing.
Yeah.
Looking at the book of days, right? Planning your staffing out. When you have 16 nurses on Tuesday but only have 5 on Sunday and Saturday. So every weekend's not a crisis.
Yep.
For every department. Foresight, planning, better planning from the higher ups. Provider response in a critical situation. Have you seen the meme for nurses? I'm sure you have. And it's like, don't respond to my messages. I'll have fun seeing you at the rapid response. Yeah, it's true.
Yeah.
Like, I know you're probably dealing with another patient, so am I, right?
Right.
If I have a critical situation, I've had to do this. I had to do this not even a year ago. The response from the provider was, we're doing handout. Right during shift change, my patient started crashing, and they responded with, we're in sign out. Okay, I'll see you at this rapid response. This lady is circling the toilet. Yeah, so, and 10 minutes later, they were squeezing the blood by hand into her body. So just like providers understanding that responsiveness, communication, just like in a marriage, is one of the top things you have to have in a hospital. Critical.
Yep, absolutely.
Charge nurses and CNCs in staffing when they have other critical roles.
Oh, we're going to get some comments over that one.
Shaylee is a CNC, so we can.
What's CNC stand for?
It depends on which hospital, but the nurse in charge, the head honcho, like clinical nursing. I can't remember.
Like clinical nursing
Clinical nurse
leadership.
coordinator.
Yeah. Okay. Yeah. Because we call them patient care coordinators down here.
Okay. Yeah.
Yeah.
Like charge nurse on the unit is the charge nurse who's there for the day.
Yeah.
The CNC is like basically the manager, right under the manager.
Yeah.
They're doing your staffing.
Yep.
They're doing your chart audits. They
Yeah.
have more roles than being in staffing.
Got it.
Just because they're a warm body and we're short staffed, we're pulling them into staffing, and now their responsibilities that they were supposed to be doing are taken away because they're in staffing all day. Hot button topics, Kevin,
There you go.
that lead all of this. Just to remind y'all what we're talking about, because we get off on a lot of side tangents. Everything on this list is what is leading to inpatient, nurse, LNA, tech, lab people's burnout, anxiety, depression, mental health disorders, PTSD, all of these things. Not being treated like humans, the way people talk to us, objects, placeholders.
And that happens. That is a very valid one right there. Because I have watched people become just a number.
Placeholder.
Yep.
Okay, this was from an ER ICU RN. She works both. How we treat each other in healthcare. We already talked about that. Stressful environment all day, 12 hours. Unaware, unappreciative patients. This is not going to surprise you that this was from an ER nurse. I very highly doubt. Evil patients.
Oh, yeah.
Evil. I wanted to add that because that's just the truth. That's just the nitty gritty. We're being real.
Absolutely.
Evil patients.
Yes. Yes, we see those.
Unfortunately, sometimes those are the frequent flyers.
Yep.
Yeah.
They're there for their
I'm gonna
turkey
use some
sandwich.
dark humor here. The people you really would just DC to JC, which if you're not a medical professional, that means discharge to Jesus Christ.
Yeah, there have definitely been those that fall into that category, and it's because they're so hateful to everybody that they come in contact with. Hateful.
Right.
Just vile individuals.
You know, my family hasn't talked to me in 10 years, and you want to say, but you don't.
I wonder why.
I wonder why that is.
I wouldn't know.
I wonder why your children didn't talk to you after 30 years. But they come to the hospital and they've got let's have an empathy moment here. Let me try to have an empathy moment.
Yeah.
They're living at home, completely cut off from everyone who would ever even potentially care about them. And then when they come to the hospital and they do get care, from people who have some semblance of caring about them, right? Then they're a mirror. They give us, right, what they've been feeling. That outward response comes out to us. I am going to try to take an empathy moment. That was very good of me. From a physician, this was from an ER physician. Not leaving on time, lack of a work-life balance. For nurses, I know this is true. It's a little bit different when you're a nurse, though, because sometimes if I'm back tomorrow, I'm just like, I'll chart it tomorrow,
Yeah.
For a physician, it's not a I'll chart it tomorrow type of situation.
That's right.
It's not I'll chart that my IV for every 4 hours. I'll chart that tomorrow, right? Or my eyes and nose. I'll chart that tomorrow. For a physician that you're doing an H&P and you just saw that patient and, oh, look, it's time for me to clock out. It doesn't stop right there. And then they have kids at home. We get off at 7 o'clock at night. You want to see your kids before they go to bed. You want to see your family before it's 9 o'clock at night. And when you're a doctor writing an H&P, that could be, however long. So I get that. ER charge nurse, bad ratios, poor staffing, being security when there is none. This came from a male nurse, so that ought to tell you something. Alcohol, how you cope with your burnout is different for every person. I use dark humor in travel. For some people, it's alcohol. Then you're dealing with alcoholism, depression, and anxiety, and then still having to come to work and deal with patients. And then
it's a never-ending cycle for somebody like that. It
let's
becomes
just talk
a
about
never-ending
addiction
cycle.
for a second. Caffeine addiction. That's not one that's hurtful. But when we don't have it, try talking to me for 12 hours. Not going to happen.
If I don't have my Monster first thing in the morning, you just leave me alone.
Nicotine. How many nurses vape? How many people vape? Yep. How many people vape? How many people smoke in healthcare? How many respiratory therapists smoke?
Yeah, I love it.
All of them.
All of y'all.
All of them. We know. We see you out in your cars in the parking lot. We see you across the street at the CVS. We see you. All right, so this one came from, and I'm just making fun of respiratory therapists because it is funny how many of them smoke.
That's true.
In the ER, families' constant need, coming to the desk despite education on the call light.
You know, sometimes families are worse than the patient. And
Yes.
I know that it comes from a place of caring and concern. However, families make our jobs much more difficult. And from a pediatric standpoint, I can deal with the children all day long.
Yes.
But the parents are a whole different ballgame. That sometimes they're the hardest part of the job.
Plus, when you come to the desk, a lot of people don't know this. I wish to educate the public. This is my perfect public service announcement. When you come to the desk, while I will be helpful, I do not know you. I do not know who your grandmother is. I don't know what's going on with your grandmother,
That's
right?
right.
When you hit the call button, the person who answers or the call system is going to make sure it gets to the right person so they can help. When you come to the desk and you're staring at me with your judgy eyes, I have
Judgy
no
eyes.
clue who you are.
Yeah, 100%.
Just call the call
Judgy
line.
eyes. Yeah.
You will get help much faster. Unless it is an emergency, come to the desk. But you will get help for routine things much faster if you hit your call light.
That's a great
Plus,
PSA. Thank you.
this really does bother families, and I want to educate them too. When you come to the desk and nurses are at the computer, they are doing their job. When they see you at the nurses station sitting down, they think you're not busy. But we are, I promise. We're looking for new orders. We're charting. We are working. Even though we don't look like we're working because we're just sitting at a computer, we are working. Okay. All right. That was my little side piece. Patients getting mad when a physician lies to them. You will get a bed upstairs soon from
Lies.
the ER.
Lies.
Lie.
You finna sit there for 8 hours. Yeah, that's a lie.
Lie. I'm going to put in your discharge order right now.
Lies.
They think they're getting discharged right now. But what does the doctor do?
He goes
Goes
and
around
sees
to
the next
all his
patient.
other patients, sits down, does the discharge order 2 hours later.
Yeah.
And then they're already in their clothes as soon as the doctor leaves the room. I've been a nurse for 10 years. I can tell you right now.
Oh, absolutely. I've been the patient that had their clothes on waiting for a discharge order.
Yeah. As soon as the doctor leaves the room, they get up and they get their street clothes on. They said, I'm getting out of here. They pull out their IV. The nurse comes in 30 minutes later and they're like, oh my God, what are you doing? They're like, oh no, the doctor told me I'm discharged. Go in the computer. No order. We put that right there. It's my little soapbox. Okay. I'm getting really heated for the end of this episode, Kevin. All right, where was I at? Physicians light in, alarm fatigue, monitors, being the doctor for the residents. Let me say it louder for the people in the back. Being the doctor for the residents. And that's not your job. My job is not to help you dose some cefepime. My dose is not to help you figure out how many grams of Ancef you need to give your pre-surgical patient.
Yeah.
That's not my job. Go to your attending. Travelers not knowing about the policy and being thrown out on the floor after a one-day orientation. Preach. I've been a traveler. You get 1 day of orientation for hospital policies, 1 day on the floor, and then you're on your own. Nature of the beast, but it's not safe.
Agreed.
LNA. Patient load, acuity. Running the floor by yourself. Nurses always pushing tasks that are their job to the LNA. Higher management not listening to the workload because you're the lowest person on the totem pole. Making us get certified for more tasks when we're already short-staffed as it is, such as CMR and phlebotomy. Phlebotomy short-staffed, oh, who's the lowest person on the totem pole? LNAs, let's get them certified in phlebotomy. Oh, we don't have any CMR techs, let's get them certified in that so now we can pull a person into CMR. I could keep going.
There's a lot there.
But when the people have spoken and that's what they're saying causes burnout, anxiety, and stress, who's going to be the keeper of that knowledge?
And I would venture to say that this, if you did this same poll across all healthcare, you get probably some very similar answers.
The same answers. Yeah.
To kind of slowly bring it to a close, one of the things it's that time. One of the things that I see through that whole list is there is almost every person said something about what is clearly defined as moral injury, that you have leaders that are going against what you believe should be right. We face that over and over and over in healthcare, because most of us get into healthcare because we want to help people. We care about people. We want to make a difference. And you have leaders that have become so business minded and business focused that we forget that. And I'm not saying that I have, I'm just saying as a whole, leaders get grouped into that bunch, you know. So one of the things that I think affects our mental health more than anything that we see or do is the moral injury that we incur from our workplace or our leadership, or even the people down to the bottom of the totem pole. They feel unheard. It is up to leaders. It's really part of a leader's job to be able to listen and to make people feel heard. That in itself, that little step of taking the time to listen to someone, would solve at least part of this mental health crisis that we face. I think that we brought up some good topics.
Yeah.
I want to have an episode 3. You know, we're going to have you back on.
We had enough stuff to discuss
because there's so much.
Inpatient, there's just so much. But
Yeah.
you do have to take it in small bites, because if you bring it all as a whole, it's not going to get heard. It has to be small, obtainable bites.
Really, it's very overwhelming to hear it all at one time.
Right.
Like that list, that's a very overwhelming list. If you were to go down and break down every single topic, we'd be here for hours talking about changes that could be made.
It took 30 minutes just to go over the list. It's crazy.
Yeah. And because it's so extensive, and these are problems that plague us. So if you had, to kind of close out, if you had something to say to the leaders of healthcare today, what is it? Think about it. It's big words. It's big words for Elmo.
It's hot topic. I'm trying to think of the right PR way to say it.
You don't.
I do understand that you are in charge of a business, but that business is ran by, in your mind, ants that do a job. We are not ants. We are patients that are taking care of we are nurses that are taking care of your mother, and we are techs that are taking care of your mother. And if it was your mother in the hospital, you would be demanding the utmost care for her. Why is every patient that comes in our door less than your mother? And why are you not allowing us the safe staffing ratios and the things that we need to care for people like your mother the best possible way we can? It's inexcusable, and it needs reform, and it needs to happen yesterday.
That's good.
And we need to figure out how to do that while you're still making money.
Now, what would you say to the healthcare workers that are the ants that run the organization?
You are not ants. There's many of us, but we are all in this together. And I will stick by you. Kevin will stick by you, and we will all stick by you as our voices are heard. Eventually, it may take time, but we have to keep speaking out, keep whistleblowing, keep talking about these issues until they are heard, and until there's a light that comes to mental health and burnout in a more broader sense.
I love it. I think that's the perfect.
I'm very passionate about healthcare, Kevin. I love healthcare.
That is the perfect.
It needs reform.
That is the perfect way to end this episode. I absolutely love that.
Thank you for letting me be on. I'm a nobody.
Absolutely.
I'm just an OG inpatient nurse.
You are not
like
a nobody.
I know a thing or two because I've seen a thing or two.
Yeah. You are not a nobody. You are our Aunt KK. And to America, if America listens to this, I may have the same.
All of America.
70 people. You can be everybody's Aunt KK.
Yeah.
Of course, I love you. You are family.
I love you too.
And we are so far away, but so close right now. I could do this every week and enjoy it. Yeah, I can never do that. Yeah. Okay, I got it.
Hold on. What's the thing if you're young?
I don't know. What is that?
It's the heart. It's the Korean heart.
Oh, I see it now. Okay.
Yeah.
All right. Well, to end this
show.
We're
not of that generation.
No, apparently not, because I didn't know that. To end the show, MaKayla, thank you for being with us. You are not a nobody. I think you're big stuff. I think that you should start doing the social media thing, because this is the kind of stuff that you just sit here on camera for the last 2 hours and talk to me about this stuff.
Nobody wants to see the spawn of Satan with red hair make TikToks, okay? Nobody.
You would be surprised. Wait till next week's episode and watch that girl, that's on there. Her name's Maddie Ann. You should go look up her TikTok. She's extremely entertaining. And you could be that big, MaKayla. This is your chance at fame. Don't let it pass by.
Fame is not for me, Kevin.
I completely disagree. But anyway,
well, I love you. I've enjoyed our time together.
Thank you for
amazing.
Yeah, thank you for joining us. I love you, and we will see all you guys next week. Always check out our social media so that you can get all the ends and all the little snippets of upcoming episodes. We love sharing those. If you're interested, you can go to silentwarwithin.com. We send out a little newsletter from time to time. Got some funnies in there. Got that dark humor that everybody's looking for. So go check out all of our pages and things that we're doing. We'd love to have you along for the ride. Thank you for listening to us. And as always, be safe, take care of your mind, and we'll talk soon. Bye. Everybody.
You've been listening to A Silent War Within. If this episode resonated, please subscribe, leave a review, and share with someone who needs to hear it. Remember, you're not alone and your well-being matters. It's time to end this silent war.